All right, well, it is noon. Thank you everyone for coming and welcome to our first summer webinar series webinar of the summer. We're proud to present this series, which is going to be focused on key issues related to individuals with IDD within the state's mental health and judicial systems. This series aims to provide valuable insights into current programs, policies, and practices that impact people with intellectual and developmental disabilities. My name is Rose McBride. I'm the Communications Manager for the Texas Judicial Commission on Mental Health. And over the course of these 3 webinars, we're going to delve into topics that bridge the gap between IDD services, law, and the judicial system. So today our webinar is titled IDD 101 and the Community Safety Net, and it's going to set a foundation for the series and provide an understanding of IDD and the vital community-based programs that support individuals in accessing care, services, and resources that promote independence and quality of life. And then our July webinar is going to explore the civil commitment process for individuals with IDD to state-supported living centers under the Persons with Intellectual Disabilities Act, PIDA, with insights into how legal and procedural considerations intersect in these complex cases. And then our final webinar of the series, the August webinar, is about forensic commitment of people with IDD to SSLCs, and that'll provide a focused discussion on the forensic commitment process, highlighting the unique legal and treatment issues that arise when individuals with IDD are involved in criminal justice proceedings. And after we get started, I'm going to drop a link into the chat so you can register for these next 2 webinars. Our goal for this whole series is to equip you with the knowledge and tools to better serve individuals with IDD and improve outcomes within the judicial and mental health systems. Whether you're a legal professional, healthcare provider, or community advocate, this series will provide you with a deeper understanding of the complexities surrounding these IDD services, the commitment processes, and challenges faced by this population. So today we have 2 accomplished presenters. Dr. Evanthe Collins is the Vice President of the IDD Services Division and Agency Grants and State Contracts at the Harris Center for Mental Health and IDD. She's held multiple leadership roles that advance services for individuals with IDD and is presented nationally on topics such as trauma-informed care and stigma in mental health. We have Laura Golden, who is the System Director of Transition and Teaming at MHMR of Tarrant County, which provides services and support to people of all ages with IDD in Tarrant County. She is a licensed and registered occupational therapist, and her areas of expertise include intellectual and developmental disabilities, autism spectrum disorder, sensory processing disorder, trauma, and dementia. We will have some time at the end for some questions, so if you have any, feel free to drop them in the chat and we will answer those at the end. So welcome to both of you, and go ahead and take it away.
All right. Thank you all for allowing us to share this information about IDD and community-based resources for individuals with IDD. I have 2 disclaimers. The first one is we use a lot of acronyms in the IDD world that may be different than yours. If we use one that you are unfamiliar with, there are probably other people on this webinar that are unfamiliar with it too, so please put that in the chat if we autopilot and say an acronym that you're not familiar with. And then the second disclaimer is that I work for a Money Follows the Person or under a Money Follows the Person grant, and so I have a disclaimer that this presentation is supported by Centers for Medicare and Medicaid Services of the U.S. Department of Health and Human Services, and the contents of are those of the authors and do not necessarily represent the official views of, nor are an endorsement by CMS or HHS or the U.S. government. So now to talk about local intellectual and developmental disabilities authority services, or LIDAs, or LIDAs, or local IDD authorities, or community centers. We go by lots of different names. to the community. So I know that some of you are very familiar with your local IDD authority or your local mental health authority, but this may be new information to others of you. So I want to share some background information on local IDD authorities as we go as well. So again, IDD stands for Intellectual and Developmental Disabilities. The language was changed from mental retardation to IDD in the legal system in 2010 after Rosa's law was passed, which changed federal laws with information about the diagnosis from mental retardation to IDD. And then in 2013, the DSM or Diagnostic Statistical Manual 5 came out, which updated the language from MR to IDD. And this was all done because of the significant negative stigma associated with the R word. You may in some records still see mental retardation listed, or some physicians still, unfortunately, will write that into notes that they have, but know that those are the same thing. And now we like to use the term, and we encourage you all to use the term of IDD instead of mental retardation. So for Texas to qualify for local IDD authority services, we go based off of Medicare guidelines, which have 3 categories for classification. So the first one is an intellectual disability, which is an IQ of 69 or below prior to the age of 18. The second is autism spectrum disorder, which was diagnosed prior to the age of 22, so still in that developmental period. And then the third category that can qualify someone for services through the local IDD authority is a related condition. Common ones are cerebral palsy, spina bifida, Down syndrome, but there are over 200 related conditions that qualify for services. I do not have them all memorized. I don't expect you guys to either, but you can definitely reach out to your local IDD authority to see if someone qualifies for some of the services that we'll be talking about throughout this presentation. But basically, a related condition is something that manifests prior to the age of 22, other than a mental illness, that's found to be closely related to an intellectual disability because the conditions result in impairment of general intellectual functioning or adaptive behavior similar to that of individuals with an intellectual disability. So those require treatment and services similar to those that we would provide for someone with an intellectual disability or autism spectrum disorder. And these are likely to continue indefinitely. They result in substantial limitations in significant areas that affect major life activities. So that could be self-care, understanding or use of language, learning, mobility, self-direction, and capacity for independent living.
So thank you, Laura, for advancing the slide. Good morning, everyone. I'm Evanthe Collins with the Harris Center. I'll be talking to you a little bit about the differences between intellectual disabilities and mental illnesses. And really, this slide could have read intellectual disabilities are not equal to autism spectrum disorders and are not equal to mental illness. All 3 really are very distinct conditions, and in many cases involve distinct therapeutic approaches as well. But specifically to what we have listed here, intellectual disability, some of the differences, how we delineate between the 2 conditions is ID is always associated with limited intellectual capacity versus someone who might be diagnosed with a mental illness, could be functioning anywhere on the IQ range. Another distinction is that because intellectual disability, as Laura just pointed out, occurs during the developmental stages of life. It is a developmental disorder by definition, meaning that, as she pointed out, occurs before either the age of 18 or 22, depending upon which condition specifically you're looking at. versus a mental illness can occur at any stage of life. Well, either before age of majority or well after the age of majority, but there is no specific age range for which a mental illness is required. And the other difference is ID or intellectual disabilities are lifelong conditions, as Laura just stated, whereas certain mental illnesses where one can be restored to a level of adaptive functioning commensurate with their peers, generally that's not going to be the case with those with an intellectual disability. So although they are two distinct conditions, they can coexist in one person. So that's very important to sort of understand, because individuals with IDD, sometimes there's a misnomer that you cannot have IDD and a co-occurring mental illness, but you can. And as a matter of fact, the incident rate is 30 to 40% higher in the general public for persons with IDD to develop a co-occurring mental illness. But because many local private hospitals will use an exclusionary criteria for treating this particular population for psychiatric care, only about 10% receive appropriate mental health care. So it is common therapeutic milieux. Sometimes, again, there's misnomers that they can't participate in some of the common therapeutic milieux that are used in some of the other areas of psychiatric care. But many of the milieux used to treat the population who do have co-occurring disorders include such things as behavioral, psychosocial, cognitive, traditional counseling, such as psychotherapy, in addition to psychotropic medications that are successfully used to treat other types of mental illnesses. The most important thing to sort of focus here is that anytime that there's programming that solely focuses just on mental health or substance use approaches without taking into consideration that someone may have developmental needs, it may inadvertently exclude certain populations like our IDD population in order for them to be able to receive the needed therapeutic outcomes from those services and supports. Next slide.
There are 38 local IDD authorities in Texas. You'll get a copy of these slides and you can go to that link to find out what your local IDD authority is if you're not already familiar with them. You can just put in the county that you're in or that the person is in to see what their local IDD authority is and the contact information. And just as an additional disclaimer, you may already work with the local mental health, familiar with them, and a lot of the local IDD authorities and local mental health authorities have the same name. So MHMR of Tarrant County, LMHA, and LIDA are the same name, but some have different names. So Dallas County, for example, their local mental health authority is called North Texas Behavioral Health Authority, and their local IDD authority is called Metro Care Services. So just something to be aware of just in case. So the local IDD authorities act as the front door for essential and cost-effective services, supporting people with IDD to live where they choose and engage in community life and seek and maintain employment. Services, we'll talk about them a bit more in detail later, but overall, we focus on determining a person's eligibility, getting them enrolled into programs, getting them on the interest list for Medicaid waivers, which we'll talk about more later as well, and provide ongoing coordination or case management or service coordination to improve the individual's quality of life. And then we also have some safety nets for people because we want to keep people with IDD in the community, which is the least restrictive setting for them, and out of institutional settings like jails, state hospitals, nursing facilities, and state-supported living centers. So we're going to talk more about those safety nets on the next slide.
So as Laura pointed out, the other name that you'll hear reference, whether it's LIDA, local authority, LMHA, so forth, is the safety net, just as she stated. So just to re-emphasize, because as she stated, we'll go over specific services, and she sort of alluded to some of those services in her information about the eligibility, determining what's needed in an individual's life to keep them stable in the community, developing a plan of care, monitoring, linkages, so forth. What is most critical for this particular slide that I want to emphasize is what you heard Laura say. Our role at the local authority or the safety net is to keep people healthy, emotionally stable, physically stable in the community in which they live. It is the least restrictive. It is the more cost-effective way in order to serve someone. And honestly, it's the most humane way in which to serve someone. What's happening in terms of, and we'll get to that in some of the other slides, is that many LIDAs across Texas are either reducing or eliminating some of their provider services. And so we're having an erosion of that safety net, which means that the population doesn't just disappear because there are no available community services. What happens is they begin to decompensate and they need a higher acuity of care. And so they'll end up in one of the two prongs that you see either to the left or the right. If we can't keep them stable in the community, they're going to end up presenting either in a forensic type of situation or needing significant psychiatric care, whether that be in a psychiatric hospital or a state hospital. So ultimately, it sort of equates to a reduction of clinical programs when safety nets aren't able to do what they need to do and interventions. And at the end of the day, what unintentionally ends up happening is jails become like a zero reject or provider for this community, which is not what anyone wants or intends to happen. Next slide.
So some of the services that the local IDD authority offers that I didn't already talk about was respite, community supports, day habilitation, or something meaningful and engaging to the person during the day. So they're not sitting at home unoccupied, which can lead to some challenges if we are bored all day. Supported employment, unemployment assistance, nursing behavioral supports. So that is a behavior specialist working with the person and providing a behavior support plan or behavior intervention plan. Specialized therapies like OT, PT, speech, or occupational, physical, and speech therapy. And I have a little caveat that services are based off of state-generated revenue funding. So not all LIDAs have these services available. It is dependent on funding. Some of the LIDAs look a little different too in terms of we've sought out extra grants for additional services and supports. So for MHMR of Tarrant County, we have a grant that provides trauma therapy to individuals with IDD, but our neighboring LIDAs do not have that. And Harris Center has some additional specialized therapies and behavior support services that Tarrant County doesn't offer. So it's definitely helpful to check with your local IDD authority to see what services and supports they offer through them. Some additional services and programs that are universal to all local IDD authorities are continuity of care. This team is the access point for long-term services to an ICF or intermediate care facility program, and we'll talk about that more in a little bit. The state hospital and the state supported living centers. And then they also help with individuals for the transition out of state hospitals and out of state supported living centers and back into the community. And then all local IDD authorities also have at least one crisis intervention specialist that provides support for individuals that are in a crisis situation. They support their local MCOT or mobile crisis outreach team. They provide training and education to the community like law enforcement and first responders like our MCOT teams. And then we also have crisis respite available. Crisis respite does look different at different centers based off of potentially age qualifications. So some offer crisis respite only for minors, some offer it only for adults, or there are specific requirements based off of the facility or the services that they're offering, whether it's in-home or facility-based. And then 5 local IDD authorities are part of a pilot program that offer OBI or outpatient biopsychosocial approach for IDD services. MHMR of Tarrant County and the Harris Center are 2 of the pilot programs for this. And so they provide some additional crisis prevention and intervention services through offering collaborative care, case management, and skills training on an outpatient basis. So they provide those outpatient mental health services for people with IDD and a co-occurring mental health, substance use disorder, or behavioral support need. They are looking to expand that across the state, so stay tuned for that, because eventually, if you're not working with one of those 5 local IDD authorities, it may be coming to yours, hopefully in the near future. And then for consultation support, there are 8 transition support teams across the state, directly at your local IDD authority. Sorry, my camera just went out. Are you still able to hear me? Okay.
Yes.
All right. I'm not sure what's going on with my computer. There we go. Sorry about that. We got new computers and they've had more technical problems. So you may not have a transition support team at your local IDD authority, but your local IDD authority is still supported by a transition support team. So MHMR of Tarrant County is one of the transition support teams in the state, and we support 5 local IDD authorities. So still have access to us for consultation. Transition support teams are a multidisciplinary team that has extensive experience and knowledge working with people with IDD. The goal of transition support team is to aid in successful transition of people from institutionalized settings, so jails, state hospitals, nursing facilities, and state-supported living centers back into the community. But we also work to provide recommendations and training to help minimize the risk of someone going into those institutional settings. So we're here, transition support teams are here as a resource to kind of team through what are alternatives to those more restrictive settings. There are multiple categories for service coordination depending on a person's funding. So you might hear HCS service coordinator or Texas Home Living service coordinator or GR or General Revenue service coordinator. They all provide case management. They just are assigned to different funding sources, and some have more access to more services. So like HCS and Texas Home Living are Medicaid waivers, so they have more opportunities for more services and supports than General Revenue, which is limited by state funding that we have, and also what additional services are in the community and through Medicaid. So we'll talk about some of those more in the future slides here. And then for PASSAR, that is for people in nursing facilities, just to give a little more context there. So I'm not going to go through all of these waivers. You guys will have copies of these slides to look through, but a few things that I want to highlight is for YES waiver or youth empowerment services. This is a really great comprehensive wraparound program for individuals who have a qualifying mental health diagnosis. You can have a co-occurring IDD diagnosis as well in certain cases. But a caveat for accessing this service is that the person cannot be on probation to qualify for YES waiver. Star Plus Medicaid waiver is for people who meet nursing facility or medical necessity for that waiver. And then on this slide, HCS or home and community-based services is the only Medicaid waiver out of these that offers an out-of-home placement. So that could be a group home or a host home, which I'll talk more about in future slides. The others do provide more comprehensive Medicaid waiver-based services. They just don't provide that out-of-home placement or option. Sorry. And if you are interested in learning more about the waivers and a comparison of the different services, you can go to this website for the PDF of the breakdown of all of the waivers.
So many of you are probably familiar with the home and community-based services waiver. It is one of the most sought after waivers in Texas at this moment in time. On this slide here, you see the 5 major Texas Medicaid waivers. This slide does not include Star Plus that Laura just mentioned, but all waiver data, including the Star Plus, can be found on the HHSC website. And you can do a search for interest list reduction. And HHSC updates that information monthly, and you can get a count of the number interested across Texas and the average time on those interest lists and some of the information that is found here. When you look at across all 6 waivers, including Star Plus, unduplicated in Texas right now, as of April 2025, we have over 180,000 Texans who have expressed an interest and are officially signed up on one of these 6 waivers across our state. If you look at the particular slide under each waiver category, you can see it's noted the number interested, the average time on those interest lists. Again, you can see HCS has the largest number of people. It is, as Laura pointed out, one of the most comprehensive and sought after 16 to 17 year wait at this moment in time. You can also see the number of interest list slots approved during the 88th legislative session and the number of interest list slots approved during the 89th legislative sessions. So if you look at the top, on the top right corner where it says skip the line, individuals who are in critical need of transitioning from certain levels of care are able to apply for a Medicaid waiver without the need to be placed on the interest list. And so you'll see some of these categories here. It's not an exhaustive list, but it gives you an idea of some of those methods in which one could potentially qualify for. The first one is promoting independence. What that means is if an individual is discharging from an institutional level of care, so if they're discharging from a state hospital or if they're discharging from a state supported living center, these individuals do not have to be placed on the interest list with the for example, the 125,000 you see under HCS. They can apply to get a waiver slot. So that way, when they transition from the institutional level of care, they're able to transition into the comprehensive waiver program and have those wraparound services to keep them healthy and stable in the community and not sort of circle back or recidivism back into the other type of care. Crisis diversion means that if you're in the community and you begin to decompensate to prevent you from going into an institutional level of care, and that could be a nursing facility in addition to, as stated before, state supported living center or state hospital, you can apply for a crisis diversion to prevent you from needing to go into that more costly, restrictive level of care. Nursing facility diversion works exactly the same. Children who are aging out of CPS custody also have a particular different route in which they can apply for and receive comprehensive waiver services as well. Not listed on this particular slide, but I'll just sort of to let the group know, there's a such thing called attrition slots that's used by HHSC, particularly around the HCS category that you see on there. And what happens are attrition slots are created when there's been a previously funded HCS slot and the person has permanently discharged after their enrollment. And generally, HHSC will use attrition slots to address specific targeted groups that did not receive an allocation during that legislative session. So for example, if you look on the 88th, back at the 88th session, you can see during that point in time what our legislators allocated per waiver type. What you don't see on there, for example, is an allocation for CPS, aging out of custody. So in that example, when HHSC meets and to distribute those attrition slots, they may look to say, how many children do we have aging out of custody? And we're going to use the attrition slots to address that category because that category did not receive any funding during the legislative session. So that's in general how it works. The attrition committee meets on a monthly basis and more frequently as needed at the state level. And the actual number of slots that they will review to then reallocate is decided by their financial services. The last thing I will point out here, which will be of interest for us as a state to sort of watch, will be the impact of the recently passed HB 1188. That's known as the Henley Act. And what will be interesting is to see the statewide impact or the impact of the statewide interest list and our state's response to any significant increases to those weights. So for those of you who are not familiar, the Henley Act requires school districts to refer each student who is receiving special education services or who has an IDD diagnosis to their local IDD authority for services and public benefits, including services under Medicaid waiver programs. Traditionally, schools may have waited until the child was turning 14. That's when the traditional transition services begin in school districts. This requires them to do it immediately upon notice that that child has a disability. So in essence, we might see an increase of individuals being referred over to the LIDAs. And it's important because this act provides critical, timely information to prevent young adults from graduating from high school into home, really, or a lack of services, only to find out that there's not a plethora of community services available after they graduate. So this gives them that information early on so that families can start planning, they can get added to the appropriate wait list, and so that services will be available once that child reaches adulthood and needs them. But what you can also see on this slide is that the 89th session made no provisions for not only the allocation of slots, but no provisions for increases in local authority general revenue allocations, nor any rate enhancements for targeted case management. So one could imagine that this may be a point of advocacy during the 90th legislative session to address those exact issues. So as we increase public awareness and referrals to the LIDA for IDD care, we concurrently increase IDD funding to be able to meet those specific needs. Next slide.
So we're going to talk about some community living options to give you some background information on where people that you're interacting with IDD may be living, or some options for them as we're considering alternatives to more restrictive settings. So individuals can live in their own home or family home. Medicaid waiver is not required for this, so I can live at home with my family and not have HCS or Texas Home Living or class waiver. But I can also choose to live at home if I have one of those waivers as well. Again, HCS or Home and Community-Based Services is the only one that covers them out of home. services, but I can still receive that service and that waiver service in my family's home. I could also live in a host home or companion care home, which is similar to a family style home, but it's not someone who is my parents. So it could be an extended family member, or it could be someone that I'm not biologically related to that has opened up their home to be an HCS host home provider and provide the needed care to support the individual in their daily living skills and meet their support needs. For HCS group homes, these provide 24-hour residential assistance. There are up to 4 residents within that home that have IDD. Service coordination is provided by the LIDA, but the services listed on the right-hand column are provided by the HCS provider themselves. So the service coordinator from the local IDD authority just ensures that those services that are on the person's plan are indeed being provided, and they can bring in some extra support through recommendations from transition support team or crisis services as needed. There is an IQ component for HCS. There's a cap for it. So an IQ can exceed a certain score, with the exception of a nursing facility diversion. So again, these slots are based off of the ones Dr. Collins mentioned. And they provide some pretty comprehensive services, including nursing, dental, behavior supports, day programming, which for HCS is referred to individualized skills and socialization, or ISS, as well as some additional services listed on here. And then we have another group home alternative, which is ICF, or Community Intermediate Care Facility for people with IDD. Services are pretty similar to that of HCS in terms of what they provide. They have that 24-hour residential services, the dental, the nursing, the therapies and behavioral supports. Their day programming is structured a little differently, but the big differences are that instead of being up to 4 people, there are 6 to 8 people in an ICF home. So generally someone has a roommate. The case management is not overseen by the local IDD authority. It's overseen by that ICF provider. So local IDD authority doesn't have a lot of interactions or oversight for the ICF. There is not an IQ limit, so there could be an individual who can live in an ICF group home that has a higher IQ than all of us on here, as long as they have a qualifying related condition that was diagnosed prior to the age of 22, and they have a moderate to extreme deficit in adaptive behavior. So they really struggled with living independently and need some additional supports for living, for home and self-care, and behavior needs. There is no wait or interest list for ICF. However, it is up to the ICF to say, yes, this person is a good fit for my ICF home and I will admit them, or I have a male bed opening, but I don't have any female bed openings. So seeing what they have. So it's at the individual owner or operator discretion. HCS is a non-refusal program. So if I choose an HCS provider as my provider and they do not like the challenging behaviors that my loved one exhibits, that HCS provider still has to continue to provide services and supports for that person. In an ICF, they can choose to discharge the individual for any reason. So those challenging behaviors may become a barrier in that ICF home. So just a bit of extra information there.
And sometimes for individuals working in the criminal justice space may find challenging, to Laura's point, in looking for long-term residential placement specific in ICFs for exactly that reason, because they do have the choice to determine if someone is a best fit. So there were some studies done back in the 70s and 80s that sort of revealed, on average, approximately 10% of a jail's population was functioning within the range of an intellectual disability. So in Harris County, when we looked at the data between 2011 and 2024, there were 361 unduplicated IDD individuals who crossed the threshold of our county jail. We know that that data is underrepresented because it only includes individuals who had a history of receiving an assessment or treatment through the Harris Center. It did not include individuals who had never been evaluated by us or known to the LITA. So it would have been incumbent upon jail staff to have done some type of assessment and indicated in their records. So we know that 361 is a lower number. But when we took a look at the actual charges for those individuals that were identified, we found that trespassing happened to be the most prevalent charge for this community. So we began to speak a little bit, delve into the issue a little bit more, and start talking to some of the service providers to learn there's really been an increase or an uptick in the number of calls or complaints being made directly either by group homes themselves, and certain situations may happen where you have an IDD individual living in one of the group home settings that Laura just explained about. Perhaps two clients may not get along. Maybe someone gets frustrated at another resident. Maybe someone pushes someone, and that push may result now into the police being called, and it escalates the situation into, charges being made against the person. Or a client may push an actual service worker, and sort of the same ending results may happen. We're also seeing where community providers may also be making complaints to our law enforcement when an IDD individual elopes from a group home setting. And in some of those cases, we see where maybe a person has gotten frustrated and they just, take off and they just want to blow off, but they don't have an understanding that maybe where I'm standing or the property that I'm on, I don't necessarily have a right to be on, or the owner doesn't want me there. And so that limitation in intellectual functioning sort of cascades into a situation where now it involves law enforcement. So in many cases that we saw when we looked at our particular data for Harris County, it was not a criminal nexus at play, but more so inappropriate, maybe coping skills or maladaptive behaviors that could stem from either the person having limited expression or communication skills. And so they are emoting through their behaviors. These things at best, we feel is treated more appropriately by psychosocial therapeutic interventions, certainly not jail. So making a lot of these cases really ideal for deflection, community level, pre-arrest, or at the very least diversion post-arrest. Next slide. So early identification for us, in an effort, when we began working with some of our county jail individuals, and we do have staff, the Harris Center has staff embedded within our county jails, we wanted to aid the entire criminal justice system on how to best identify. As I stated in the slide before, we know that there's underrepresentation in the numbers because there's not really effective comprehensive screening being done for specific to IDD. So the Harris Center's IDD Service Division created, in essence, a lay screening tool to identify those who might be functioning in a range of intellectual disability or an autism spectrum disorder. The tool can be used by any staff, probation officer, attorney, anybody working in the jail. It is truly a layman's tool. And what happens is a positive screen triggers a referral over back to the LITA, or the local authority, IDD authority, our eligibility department, and they complete the official assessment known as a Determination of Intellectual Disability, or a DID. And once that's done, that will give someone access to some of the services and supports that we've been talking to you guys this afternoon about. But you need that eligibility screening in order to be able to access those long-term supports. Next slide. The other thing that happens is we created a care pathway. So as individuals who are working in the criminal justice system come across a positive trigger, they're able to have a specific care pathway where they communicate directly with our eligibility staff. So if the person, for example, maybe they don't need a full-blown assessment because they've come through the local authority before, but maybe the attorney working with the client needs to know what type of services has this person been receiving, what services are available in the community to help them stabilize so that we can come up with a great disposition for the case. We're able to work with the criminal justice individuals to be able to provide that information to them in a quick, seamless way so that they can quickly get the information that they need. This here's the actual screening tool. It's, again, very simplistic. These tools, and you can go to the next slide. This tool right here is specifically for IDD. The next one is for autism spectrum disorders. You can see it's just a few simple questions. Both tools can be completed either by questioning the actual individual, if they have appropriate communication skills to be able to relay that information, or his or her support system, or in some cases by direct observation. You can get some of this information. I want to point out the key component here is the collaboration. Because without the collaboration, it sort of goes nowhere. The collaboration between the lay screener and the local authority is paramount. Screening assessments really can be Googled. I mean, there are plenty out there that one could avail yourself to. But what happens if a positive screen is triggered, right? And you have no place for that to go and people to work or collaborate with in order to know what can be done about the case. So information and a care pathway must be established between the screener and the local authority because, again, that eligibility that is required to access HHSC state general revenue funding and to ultimately give criminal justice individuals who are working with the case information that they need for the disposition of the legal case is going to be very important. Next slide.
So you will hear more about this in future webinars, part of the series, but the wait for a state-supported living center for a civil commitment is about a year long, and for a forensic commitment, it is at least a year and a half. So we're looking at a really long time for those as options for the person. And for those forensically, jail is not the best place for someone to wait for a year for an SSLC. I've seen decompensation happen pretty quickly within just a few weeks of being in jail. And if we're thinking about months and a year or longer, we see some pretty significant decompensation of the individual in terms of their skills, in terms of their communication, especially because per our local IDD authority handbook, we have to collaborate with correctional facilities to ensure that our person with IDD is moved out of general population and put in a single cell for their safety. So that is a lot of social isolation there, but also thinking from the jail side of things, that's a really long time for a single cell to be held up for a person when we know that we need those cells for other individuals. So we're going to talk about some options for individuals as alternatives to state-supported living centers. So we at the local IDD authority always have to look at the less restrictive setting. There's guidelines for determining the less restrictive settings in the TAC rules, or Texas Administrative Code. I encourage you all to look at that to help provide some preliminary summary and aiding in discussing and determining if a client can be adequately and appropriately served in and habilitated in an available, less restrictive setting, when SSLC is up for discussion. So this is what we have to do as local IDD authority staff, but helpful for you guys as well. So some alternative options to the SSLC are out-of-home placement. A lot of forensic cases that we have in Tarrant County are related to domestic violence, and it's with a particular caregiver. So usually it is a parent. And so if we can see the history that they don't have physical aggression with other individuals that come into the home, other family members, if they go to a day program, that they don't have physical aggression with other people at day program or in school, this is a good indicator that they may do well in an out-of-home placement, such as an ICF, an HCS group home, or a host home. And then also sometimes it is just the person doesn't have adequate coping skills and they need behavior supports, or they need therapeutic interventions through a program like our crisis intervention services or OBI, that can help meet those needs. And sometimes we need to do that in an out-of-home setting like a HCS group home or a host home, and then that person might be able to transition back into their family home. Probation is also an option to be considered for individuals, and you can have caveats and conditional dismissals where we specify we know that mom is the trigger or dad is the trigger. And so the conditional dismissal or part of the probation is that the person has to live in an out-of-home placement. I worked with an individual who was in an SSLC, discharged to a group home, did really well in the group home. We knew challenges leading up to him going to the SSLC the first time were because of conflicts with father. After his year-long following from the SSLC in the community, he was then allowed to choose where he lived, and he chose to go back to family's home, which we thought might be a challenge. He ended up being arrested for domestic violence towards his father. And if he had had that restriction in place that he can't live with family, that he had to remain in an HCS group home or a host home that was not with family, he would still be in the community today. Some other community creative solutions are to involve the crisis intervention specialist, engage with CIT and mental health deputy for support, community first choice, which provides attendant care for the person to help build independent living skills, some skills training through specialized programs that we have through our local mental health authority or through some of the specific specialized IDD authority programs. Or through ABA or behavior specialists, anger management classes, meaningful engagement, a lot of challenges like trespassing or other illegal activities that our people are arrested for are because they're bored during the day and they don't have anything meaningful and engaging to do. So that could be a stipulation. You have to volunteer. You have to be at day programming, you have to have employment, something that fills that person's day with something that brings meaning and purpose to them. Medication compliance has also been a challenge for some of our individuals that has led to some legal involvement. And so you can recommend injectable medications if there's an injectable alternative to their medication. And counseling is so helpful for everyone, and we have ways to adapt counseling to meet different cognitive and communication abilities. So please reach out to the transition support teams for support for that. Because counseling is not just helpful for someone who's experienced trauma, but for someone who has had trouble with their family system, who has been in jail and transitioning back to the community, for someone who's having some difficulty with just regulating their emotions and understanding how best do I respond when I feel this emotion. And again, know what services your local IDD authority offers so that we can help with planning for some creative solutions that may or may not be on this list. So there may be some other ones that we just don't know about because MHMR of Tarrant County and the Harris Center don't offer those.
So this is our diversion center in Harris County. It opened in 2018. It basically is set up as most diversion centers are, as voluntary, low-level, non-violent offenses. You can see the services that we offer there: psychiatric, nursing, med management, psychotherapy, wraparound supports. To date, since 2018, we have successfully diverted over 13,000 individuals from our Harris County Jail through the use of this particular program. Diversion programs work. There's enough evidence-based data, empirical data around what they're able to accomplish and the outcomes. We had ours independently studied back in 2024, and the data revealed that individuals who went through the treatment program versus the control group 1.3 times less likely to have a new subsequent charges within a 12-month period. Those who had five plus more bookings prior to going to the diversion center were 3.1 times more likely. The cost savings is also pretty evident. For every dollar we spend at diversion, we save $5.54 from it being spent for treating that person in a jail setting. Right now, we have this Ed Emmett Mental Health Diversion Center for the entirety of Harris County with a 4.8 million population. So what we're in the process of doing is to operationalize additional either mental health focused diversion centers, and what we are hoping to be a first, an IDD specific deflection center, which will also serve as a step down model for individuals with IDD who are being discharged from either a hospital type setting or an institutional level setting, but they need a little bit more supplementary type of care before actually going back into the community to live long term. And it also serves as crisis respite as well for that particular population. So in essence, what we're trying to create is like a network of alternative care whereby law enforcement will have geographic ease of access to take people to an alternative therapeutic setting as opposed to taking them to jail. Next.
Tarrant County also has a jail diversion center, and anytime we have someone with an IDD or suspected IDD diagnosis, our crisis team is notified and we connect with them to get them connected to services through MHMR or the community, or if they're already connected to services, we work with their support system to determine what is the cause of these legal involvements and how can we reduce it so we have less recidivism and less police interactions for in the future. Some final points on how to help people you serve: propose creative solutions to the state or come up with some creative solutions based off of things that we've talked about as alternatives to help meet the person's needs and reduce recidivism. Provide documentation of IDD diagnosis if available if you work for the DA, to the defense, or if you work for the defense, to the DA, showing that determination of intellectual disability, psychological testing prior to the age of 18, if they had an IEP or 504 plan, because knowing if they have a qualifying diagnosis opens up the doors for additional services and other options for these individuals that are better than sitting in jail for a really long time waiting on services and just decompensating. And then again, consult with your local IDD authority or the transition support team to help with coming up with some alternatives or creative solutions for them. We're going to open it up for questions. I know we only have a few minutes, but I also wanted to share that you are welcome to contact either of us if you have additional questions. In addition to contacting your local IDD authority, I would start there, but we can help with some additional situations.
Thank you both so much. We have a couple questions in the chat. I think we only really have time for one or two, but we'll start out with, how does someone skip the line for the waivers? Do they have to tell HHSC on their own, or does the facility help?
So it depends upon the setting that they're coming from. If you're being discharged, for example, from a state supported living center, your team, your transition team at the state supported living center will facilitate that process. If you are currently in the community and you're needing a crisis diversion because there's decompensation happening, you reach out to your LIDA, and a service coordinator at that LIDA will do all the paperwork and walk you through that entire process. But you, in general, you're not necessarily reaching out to HHSC on your own. You're going to have the help depending upon what setting you're coming from.
Okay, and one final one just came in. Is there an age requirement for someone being diagnosed with a related condition?
So it has to be prior to the age of 22, but some historical knowledge can also help. So if a caregiver can speak to, they've had these signs and symptoms of autism prior to the age of 22. We saw this as they were growing up. That is also helpful for establishing that age of onset. Because we know that some people don't get diagnosed with autism until they're in their 30s, 40s, 60s sometimes.
All right, well, I think we are out of time. I am going to take over the screen real quick. And this is the CLE number with a QR code to scan that, our website for the JCMH, and our email. This has been recorded. I'm going to put it on our YouTube channel and send everyone a link to the slides as well as the full video if you'd like to rewatch it. And I dropped a link in the chat earlier to sign up for our next 2 webinars. But thank you everyone for attending, and thank you to Dr. Collins and Laura for presenting. We really appreciate it.
Thank you so much.